Well, good morning, everybody. I'm Dr. Joshua Sellner, and I'm here with Kim Jenkins. Kim Jenkins is our real lead on our Maternal Morbidity Mortality Review Committee. Sometimes I forget that extra M in there. And today we're going to be talking about our new 2024 legislative brief that just hit the presses. So we can go on to the next slide. So this is our 8th South Carolina SCMMRC legislative brief. Each year's gotten a little bit better. Really, as we get more data, we're allowed to do more with it. As we know, maternal deaths are a relatively rare condition. So once we're looking at pregnancy-related deaths, our sample sizes tend to be a little bit limited. So with that, we can't quite do as much as what we might be able to do with some of our other data with more common diseases like diabetes or heart disease, such as getting down to that county level. The legislative brief is submitted by March 1st each year, and it is legislatively mandated for us to do it by that date. So we did meet that deadline this year, so we were happy to do that. The data presented today is including data from 2018 to 2020. And we've been getting the complete data collection since 2018. Before that, it was more of a sample of cases, kind of like what we're doing right now with Beamer, as we're working to try to do a more comprehensive approach in the future. So a little bit about the MMRC process. Essentially, all of this comes down to we have a lot of different data sources feeding into our system. So we're not just looking at one thing. We're not only looking at vital records data. We're not only looking at our hospital data. A lot of our information starts with vital records and generating the maternal death certificates, which are then linked to our live birth certificates and our fetal death certificates, which are then going into this new database called Steve by NAPSIS. Once we get that information, we're combining it in with our out-of-state deaths, LexisNexis, and facility reporting, which are all going into our main database of record for maternal mortality information in South Carolina, which is termed MARIA. The abstractors are then taking the information out of MARIA and pulling law enforcement reports, coroner records, autopsy reports, medical records, family interviews, countless other data sources, really any and everything that can really inform, what really happened behind this death. And they're using that information to generate a case narrative. And then from that case narrative, we're going into, we have a subcommittee and we have a full committee. Those deaths that are, potentially pregnancy associated, not pregnancy related, we put those through the subcommittee. If the subcommittee then deems that it has the potential to be a pregnancy-related death, then the case is then presented at the full committee. From there, the committee decision form is completed and goes right back out into MARIA, where our epidemiologists then pick up the information and take on the analysis, reporting, and dissemination. So this is our legislative brief through the years. So you can see it's made a lot of improvements. It started off as a 1-pager, slowly progressed to a 2-pager. I believe now we're sitting at 5 pages. One of my goals, which I did not meet this year, was really bringing the page number down to make it a little bit more accessible. Instead of that, now what we're doing is creating kind of branched reports. So still having the legislative brief that's presenting all of the necessary information, but then we're working on different data products such as mental health and racial equity, where those can turn into 1-pagers and still be housed on DHEC's website so people can get a little bit more information. We've also been working on an interactive data dashboard that we hope to bring live this year with the support of a CSTE fellow. Yeah, you can see throughout the years, it has definitely changed its shape, its form. And this was the first year that our communications department took the information that we provided and kind of made it more DHEC-y. No, that's not a real word, but it's fine. So using all those DHEC colors, being very similar to other DHEC products, really just trying to create that brand there, but still relaying the information in the most useful way possible. Go on. So here's the 5 pages that I talked about. Generally on these briefs, I try not to use staples, but that would limit us to the 2 pages front and back. So we do unfortunately have to use the staples. So that first page is really where we wanted to put the most important information. So the high level, how many cases were reviewed, what's the pregnancy-related mortality rate by year, and what's it by race. As you know, us tackling these racial disparities has been a critical issue for DHEC for many years now, and it's something that we really want to bring to the front and highlight as much as possible. That second page is taking a little bit more detail or a deeper dive into the geographic associations. So this was the first year that we were able to present the pregnancy-related mortality ratio at the region level. Kind of like what I said earlier, we're not able to get down to the county level on most counties just because of the limited number of cases, only over the 3 years, 18, 19, and 20. On that second page, we're also tapping into the leading causes of pregnancy-related deaths, still presenting them as that 2018 to 2020, but we did have a little sidebar on the right side that we're then hopping into what's different with 2020. So it's one thing to have that, trend over time or just aggregated results, but another thing to say, what's different about this year compared to all the other years. That third page is when we're tackling the timing and the preventability along with the circumstances. And we do a nice little focus piece on discrimination, really defining what discrimination means. We've heard a few different misinterpretations of that, so we wanted to really highlight that to make it as clear as possible. Then onto the fourth page, this is where we talk about our pregnancy-related deaths by payer source. So looking at the percent of these pregnancy-related deaths and who's paying for these births. Then we're looking at it by age. We have the key takeaways and summary. And then that final page, that fifth page, is where we get into really the meat of it and why we do all of this is to generate these recommendations. So again, we're looking at all this data to really try to generate these recommendations to improve health outcomes from there. We can have pretty pictures all day, but if we're not making decisions based off of them, then, why are we wasting our time? We can go on. So on this front page, first want to kind of clarify what is this pregnancy-related mortality rate ratio. You'll hear a couple different ways to describe that. But for 2020, we had 79 cases reviewed. Of those, 18 were termed as pregnancy-related deaths. We then take the 18 pregnancy-related deaths over the live births for that 2020 year, which was 55,713. Make it into a whole number. That's really what that 100,000 down there is. And that's where we end up at our declining pregnancy-related mortality ratio for the first time in 2020. So we saw in 2018, we're at 35.3. 2019, we did increase to 38.6. And we did have that, surface level success of 2020, this pregnancy-related mortality rate coming down. But then when you're looking to the right side of that graph, this is where we split it up by race. So here we're looking at white and black. We do capture all the races according to the OMB 97 standards. But again, with our limited sample, right now we're only able to show our white and black racial disparities. Next year, we should have enough data to start presenting out Hispanics. So then we'll split this into non-Hispanic white, non-Hispanic black, and Hispanics from there. But we can see, well, overall in South Carolina, we had this decline in our pregnancy-related mortality ratio. It's primarily driven by our white population. So our white population has gone from that 26.8 to 24.1 and way down there to 16.4. And then on the opposite side of that, we have our Black population across South Carolina really skyrocketing in their pregnancy-related mortality rate. So going from 34.3 to 61.9 and even higher to this last year at 69.1. So we had to play around a little bit about where to place these graphs. So we didn't want to give that false win of declining pregnancy-related mortality rate. We really wanted to be as clear as possible on this, that if all of our populations aren't excelling, then none of us are excelling. So we really need to be focusing on these Black pregnancy-related mortality deaths that are happening across the state at a greatly disproportionate rate. I think this comes up to about 4.2 times the rate as their white counterparts. So for every one white pregnancy-related death, we have 4 other Black pregnancy-related deaths. So definitely one of those big numbers that we want to be tackling from there. We can go on. And then here's when we break it into rurality. So using the South Carolina Office of Rural Health's definition of county rurality, which I know there's plenty of different definitions with rurality. There's treating it as kind of a continuous variable. There's the dichotomy of rural versus urban, a couple different data sources, depending on if you use census, but we try to align with our partners on how they're classifying this. Really, this is what they do every day. So we take the counties that are classified as rural, and we take the counties that are classified as urban. We then divide out the total number of live births for the denominator across both of those, and then put those pregnancy-related deaths as that numerator. And here you can see that in our rural counties, we have a much, much higher pregnancy-related mortality rate than in our urban counties. So we wanted to kind of emphasize this on the impact of rurality on pregnancy-related deaths have increased from 70% higher to 92% higher among our rural counties. You can take this even further and break it out by urban, rural, white, Black. And there you can also see an interactive effect where we know that our Black population is disproportionately impacted, our rural populations are disproportionately impacted, but our Black rural populations are even higher, are experiencing an even higher disparity than any of those others from there, really on an interactive scale. And then to the right of that, kind of what I mentioned, we have our first ability to show each region across the state, where we can see that really our focus is up there on the upstate, where we have the highest pregnancy-related mortality ratio at 45.2, with our lowest right next to it in the Midlands at 29.0. So significantly higher in the upstate than it is the Midlands, with the PD and low country kind of falling in the middle and a little bit more similar from there. Below that, we see the leading cause of pregnancy-related deaths from 2018 to 2020. And here's where we see that our mental health conditions and our substance use disorder has risen to the top. So now at 15% of these pregnancy-related deaths being attributable to these mental health conditions. Followed by that is our thrombotic embolisms and cardiomyopathy tied for that second place. And then we have infections and hemorrhage tied in next, and then our cardiovascular conditions down there at the bottom. And then we see some of these differences in 2020 where not really a difference, kind of a similarity, but our mental health conditions, substance use disorders continue to be a leading cause of death. This is one of those that kind of varies on its placement on being first or second, but it continues to be a leading cause of death on each year of our reports. Cardiomyopathy, the leading cause of death in 2019, declined in 2020. So that's one of those that you see over there that dropped down to tying for a second place. And our thrombotic embolisms became a leading cause of death in 2020. So that was not really on the radar before, and now it rose up to being a pregnancy-related death or a leading cause of it. Go on to the next slide. And now for our third page, we're looking at our timing of pregnancy-related deaths. And here we're seeing the majority of pregnancy-related deaths occurring during the postpartum period. So while a lot of people think these pregnancy-related deaths are happening while someone's pregnant that day of delivery, we're seeing that day of delivery is only accounting for about 15% of these deaths. And then combining in with that while pregnant as well, we're still only sitting just over about 30%. Whereas we have the highest time point being this 43 days to 1 year. And this is also one of the graphs that we were able to take that deeper dive into this year. Before, I believe we used 3 to 4 categories. Now we're using 5 categories. So again, as we're getting more data, we're able to get a more clear picture of what's happening across the state and really use that information to drive the action from there. To the right side of that, we see our preventability of our pregnancy-related deaths. And here we see that this is an inclining preventability over the years. So in 2018, we only had 3/4 of our pregnancy-related deaths being termed as preventable. In 2019, that rose up to 81.8%. And in 2020, that rose even further to 94.4%. So we should be looking at these preventable pregnancy-related deaths as the opportunity. If it's not preventable, it's really hard for us to have an impact on that. But with 94.4% of these pregnancy-related deaths being preventable, that's really just screaming that we have plenty of opportunity here to make a change and have a difference here that's going to be solving some of these issues that we're seeing. Down here on the bottom, we have circumstances of pregnancy-related deaths, where we see that the leading circumstance is 36.4% being discrimination, followed by 28.3% obesity, 25% substance use disorder, and 25% mental health conditions. And again, on that right side, we really wanted to define what discrimination is directly based off of that case report form, where our committee decision form, I'm sorry, I still got COVID in mind, where we define it for the committee to then decide from there. So not trying to discount the impact of discrimination, but really trying to be as clear as possible on what discrimination means. And with this definition, it is the possibility of discrimination is described as treating someone less or more favorably based on the group, class, or category they belong to, resulting from biases, prejudices, and stereotyping. It can manifest as differences in care, clinical communication, and shared decision-making. So again, it's not just saying this is a race thing. This is saying really anything. Was anybody discriminated against, looking at group, class, category they belong to. So surpasses way past just looking at race. We can go on to the next slide. And here we see our pregnancy-related deaths by payer source. We did try to change this one into a rate like everything else is presented, these pregnancy-related mortality rates. Really, making it an apples to apples comparison, looking at the number of people that gave births that were paid for by Medicaid, and then of those, how many pregnancy-related deaths did we have? But we were only able to show it for 2 of the categories, so we feel like next year we should have enough data that we'll be able to present these as rates. Regardless, we still see disproportionately higher among our Medicaid population. Yes, majority of births across the state are paid for by Medicaid, but even given that, still a greater proportion of those that are paid for by Medicaid result in a pregnancy-related death compared to private, self-pay, or other from there. On the right side, we see our pregnancy-related mortality rate by age. This one shouldn't be too surprising for y'all, where we see the inclining rate over time, really with that 40 to 44 age group, skyrocketing up there to 123.6, compared to those less than 20 at only 9.9, and those at the 20 to 24 at the 32.2. So our key takeaways from all of this is our pregnancy-related deaths declined, but our racial disparities widened, and the majority of pregnancy-related deaths occurred in the postpartum period. Again, that's one of those points we really want to drive home for our populations across the state to really be advancing some of our programs to try to counter these disparities and negative associations that we are seeing. We can go on to the next slide. And our recommendations from this year is really increasing our access, working on care coordination, clinical assessment, knowledge, policy and procedure and adherence, discrimination, policy and procedure, referral, and coroner recommendations. So really split in those major categories going across with some more recommendations nested within those from there. You can go on to the next slide. So again, want to highlight those new items this year. We have that DHEC region map where we're presenting the pregnancy-related mortality ratio. We have our disaggregated timing of death, where we previously had 3 levels. Now we're displaying it at 5 levels. And lastly, the changes in pregnancy-related deaths over time. So really highlighting what's new in that last year, where we had that 2020 box up to the right, and then our aggregated 18 to 20 on the left side. And again, some of these highlights that we already discussed. In 2020, South Carolina saw a 16.3% decrease in the overall pregnancy-related mortality ratio. Racial disparities widened, with Black women dying 4 times more than white women, and the majority of pregnancy-related deaths occurring in the postpartum period. Next steps. So I mentioned before how we have, we're focusing on our mental health side, we're focusing on the racial disparities. So we formed 2 work groups where we have volunteers working across our mental health and racial disparities work groups, taking those deeper dives, looking at the data, and then trying to figure out the true story of what happened. And then the idea between those is coming back to that full committee and kind of reporting back out to them to then advance some of those recommendations. That really is the cream of the crop of what we're doing here today. We're also in the process of applying for funding for MMRC to increase the sustainability of it. So Kim Jenkins has been leading the grant application process, and she's been doing an amazing job at that. So I'm really excited to see the sustainability of our MMRC program increasing over time. And lastly, what we're always doing is developing actionable recommendations. Again, we're not just collecting data to make pretty graphs. We really want decisions to be based off this data, be data-driven decisions. And that's it for me. Here's my email address if anyone does have any questions past this. If you think of something late at night, tomorrow, whenever, feel free to always drop me an email and we'll be able to get right back to you. So, thank you all.
Thank you so much, Dr. Sellner. So if I asked if you can please place your email into the chat to everyone as well, so they can just copy and paste. And I will leave this up here for a moment so that you can write down Dr. Sellner's information. And I'm going to go ahead and just pull up those questions one more time, and then yes.
Can I interject your question?
Give us 1 second. 1 second.